Our next speaker is my co-chair, Professor Charles McGee from New Zealand, Auckland. He's going to speak on repairing and replacing the iris. So we pass the time to Charles.
Thank you. That was an excellent presentation, Geeta. I'm going to talk about, further down the line, talking about replacing the iris, particularly intracapsular, sulcus, and sutured artificial irises. I have no financial interest in anything I'm presenting. So how do we deal with iris defects? Well, we can use cosmetic contact lenses, dark glasses, corneal tattoo and peripheral lesions, iris sutures, intracapsular segments, sutured aniridic IOLs. And what I'll concentrate most of my talk on artificial irises in various positions. Dark glasses are fairly straightforward, but you'll hear more about contact lenses later, but we can look at transparent tinting, opaque designs, and custom hand painted. This case here is just off-the-shelf contact lens, which works very well for this patient with Uret-Zavalier syndrome. Here's a case of floppy iris syndrome during phaco, extensive disruption of the iris. It's pretty threadbare, it's distorted, but relatively easy to fix with just 2 stitches using the 4-throw no-knot technique pioneered by Agarwal and others. What about artificial irises? They've been around longer than you might imagine, since the 1960s, and these images on your right are the various choice, as in Peter Choice, artificial irises with incorporated IOLs. However, they were largely unsuccessful because they were complicated by angle changes, UGG syndrome, and corneal failure. Morcare, however, developed a large prosthetic PMMA IOL with a black aniridic iris surround, and it worked very well from 1990 until the last 5 or 6 years, when it was supplanted by the newer artificial irises. Optec also developed aniridic IOLs and segments in a variety of colors, and those colors were sometimes quite dramatic and actually drew attention rather than deflected from the defect. Volker, Rasch, and Morcher produced the first injectable prosthetic IOL, iris, and then Koch and Human Optics persevered to design a silicon unit, which is now widely used and actually had FDA approval in 2018. So these are some of the older, but still around, techniques. This is a variety of combined IOL artificial iris insertions. These are for aphakic guys with iris defects. The Optec lenses are above, the Morcare are below. I enjoyed putting these in over the years. You no longer have them readily available in most markets. So here we see a case with traumatic mydriasis, cataract, severe glare, and a corrected vision of 636, guarded prognosis due to blunt trauma. We did the cataract. You can see the edge of the rexus inserted, 2 iris segments, and then an IOL. And when the pupil is its normal size, you can see we've restored a fairly reasonable pupil size with 6/12 vision. These are slightly more difficult to put in, but through a smaller incision, 2 segments which interdigitate, in this case, another blunt trauma case, and we successfully reduced the pupil from around about 9 millimeters to 4 millimeters. You also have to preserve any tissue you have. In this case, the lens is being held up in part by superior zonules and the iris segment that remains. In fact, the pupil is at the very bottom of the screen. But here again, you can do a cataract. We put in thin segments. We didn't want to stretch the bag too much. And this patient got a 6 millimeter pupil and restored visual acuity. Sutured aniridic IOLs require a big incision. They work very well in those who've had severe trauma and have lost most of the iris and the vitreous. It's a globe rupture, one of the first ones I did in 2003. I saw this patient early last year, and he still maintains 6/9 vision 20 years down the track. The main issue here is using a no-touch technique with your sutures, or the Prolene won't last. But even so, 20 years for Proline is pretty good. However, in 2011, I changed the way I started doing these and looked at new approaches and started using artificial irides. This is one of my first cases. Severe trauma, retinal detachment, macular hemorrhage, good peripheral vision but no central vision. It's a very guarded prognosis but suffered severe glare. I went ahead and sutured in an IOL and an artificial iris, and she was happy with the result. What is the human optics artificial iris? I have no interest in this physically. It's a pigmented silicone design. It's either got fibre if you want to stitch it, or no fibre if you want to put it in the bag or the sulcus. You can get it bespoke to match the pupil, the iris colour of the opposite eye, or you can get an off-the-shelf one as a standard colour. It can be folded or injected. You can put it in 3 main positions: ciliary sulcus, endocapsular, or suture to the sclera. It was FDA approved in 2018. What we've done about, this is data in December, we've done a few more. With 75 eyes in New Zealand, about 64 in Auckland and 54 with my team. Why we're mainly doing them and how we're doing them? Well, mainly we're putting them in the bag. We're not doing so many sutured or sulcus-based. The indication, largely trauma, but also excision of iris tumour, since we are the country's centre for excision of iris melanoma. Clearly, these are not designed to change iris colour. This is a major intervention. We use a mite incision when removing the iris tumours, minimal iris touch excisions. You use 4 1mm incisions, 1 standard phaco incision, and you can remove most tumours from the eye this way, leaving it suitable to then go ahead, depending on the histology, with reconstruction. Here's one of our early cases. The lens is already in the bag. We've folded the artificial iris. This is a melanoma excision before. You have to center the lens well, because once the iris is in, it's more difficult. So we've centered the lens. We've got the iris in the bag. Then obviously remove all viscoelastic. And post-operatively, it looks pretty good compared to preoperative. But further down the line, one of the beauties is you can see into the angle still. You can still see the ciliary processes. By putting the artificial iris in the bag, you're enabled to continue to observe the case. This patient also had proton beam therapy because it was a high-risk tumour with a little residual peripheral iris there. But at 8 years, the patient was still seeing 6, 7.5. What is the standard technique? Well, standard phaco of your choice, 2 paracentesis incisions. You need to stain the capsule well so you can see it when you're inserting. You need a larger capsular X, about 6 millimeters. Again, center the lens before you unfold the iris. So we're centering the lens there, then we let the iris unfold. We're using second instrument to keep the iris folded. Unfold 1 leaf and keep the iris pressed back into the bag. Then we use a second instrument to unfold the second leaf. And often the only significant manipulation is the trailing edge. If the trailing edge doesn't go in properly, in which case you have to fold it into the bag, or you can pull it into the bag. And it's critical that the iris is entirely in the bag or it will vault forward. This is an aniridia. This is a bilateral congenital aniridic, overwear of contact lenses, plus vascularization, plus early limbal stem cell compromise. So we did bilateral clear lens extraction with the iris in the bag. Here we're using a second instrument, a microforceps, to pull on the trailing edge to place it in the bag. And again, in this case, you can actually see the well-stained capsule is covering most of the, well, it's covering all of the periphery of the iris. What does it look like? This is day 1 in the right eye. You can see the pupil is not quite perfect shape because we've retained 70% of the patient's iris. This patient obtained 6/6 vision. You can also put in scleral sutured iris IOL. You can either use a belt loop technique to attach the 3-piece lens to the iris and then suture in or otherwise fixate the iris. Or you can actually physically stitch the lens to the iris and then suture in the iris to sclera. And you can see in these cases, these are complex cases requiring pars plana vitrectomy. One of the easier ones, this is Uretza Valier following a glaucoma procedure. They had very high pressure, the pupil was enormous. We have already had a cataract procedure performed at the time of the glaucoma procedure. And we went ahead, matched the iris for colour, and inserted an artificial iris into the sulcus. We also did an ultra-thin DSEC, and the patient achieved 6/6 corrected vision at 2 months. Here are some other examples of irises seen up close, where we've put in artificial irises. D is day one with a very complex iris pattern, which is well matched by a bespoke iris. These patients generally do well. Of course, you do have some complications. If we look at the first 19 cases of in the bag, with more than 14 months follow-up, there were no lines lost of best corrected visual acuity. Overall satisfaction was high. There were some mild or self-limiting complications. Obviously, an IOP spike, you need a lot of viscoelastic to do this. Cystoid macular edema was more common, being about up to 15%. And that's probably because these patients have had trauma or iris surgery before they go on to have artificial iris surgery. The only moderate complication we had was one vaulting of prosthesis. Now that we've done more than 60, we've had 2 prostheses vault. You do put in a CTR at the time to try and keep the capsule in tension. But in these cases, you can trim the iris and put a suture in and leave it in the bag. I think one of the main things to note is the instant loss of accommodation in younger patients is really notable. So we're now considering we should put an EDOF lens in for those patients under 40. So how would we summarize this? Always consider, always consider conservative approaches. Tinted lenses work well, spectacles work well. Focal loss may work well with a peripheral corneal tattoo. If the iris is viable and not too scarred, you may be able to repair it by suturing it. Anoritic IOLs and iris segments are no longer available in many markets, unfortunately. Artificial irides are suitable for insertion with IOLs in the sulcus, in the bag, and scleral sutured. Beware of cystoid macular edema and low-grade uveitis. These patients need to be on topical steroids for 2 to 3 months. And acute presbyopia impinges on satisfaction. Only remains to thank the many colleagues, both consultant and the many fellows who've worked on many of these projects over the years.